So there are several indications for a Thomas splint, okay? One of the indications here, it immobilizes femur fracture, okay? Any fracture within the femur, it normally immobilizes. And the reason of immobilization normally relieves pain, okay? And that's the most important thing. You want the patient to be pain-free. Otherwise, you'll be called every 5-15 minutes. Patient's in pain, give morphine. Give tramadol, okay? So if you immobilize and you make sure the patient is pain-free, it will mean you will be giving maybe TDS of painkillers, okay? The other thing is as a first aid measure. So you've been called in a home and a lady has fallen down and you've come in, you're like, oh, this is a fracture femur from your clinical assessment, okay? The leg is shortened and all those signs, okay? So what you do, you can put your Thomas splint as you transport the patient to a facility. The other thing, as transportation of injured patients, the other thing is for joint diseases like knee TB. So if you have knee TB, you know it's eroded and all that, one of the other measures they normally use is a skin traction to relieve the pain. Okay, so what do you need for a skin traction? Okay, you need a Thomas splint. I know all the low resource setting has Thomas splint, I presume, right? And then you need a skin traction. And a skin traction, I think it's something every facility has, right? So this is the skin traction. I'm not going to remove this plaster, okay? The adhesive. So this is the skin traction kit, okay? And then you need the crepe, the elastic crepe, okay? So you need only how many things? 1, 2, 3. Okay, so this is your 45-year-old man with a fracture femur, okay? So what happens? You guys have given boluses of morphine, you've given tramadol, so you want to immobilize. And immobilization means you have to reduce the joint, okay? Because there is an overlap and all that, so you have to pull your leg. At the same time, you have to immobilize. So when you do this thing, it's going to be very, very painful. When you give me morphine, it's going to make me laxed, okay? I'm going to be like in another lucid environment, but I want to be pain-free. If you give me tramadol, the same thing happens. You think you're making the patient pain-free, but you're not. So what happens if you're a person, if you have the capacity to do this, you can give a nerve block, okay? A femoral nerve block. It's one of the easiest block you can ever do. Because you have, when you pulse, you touch your pulse, you have the femoral artery, okay? Next to your femoral artery is your femoral vein. That is medially. Laterally, you have what? The nerve. So anytime you pulsate, you look for your left side, the lateral side. That's where your nerve is. So you can take your 10 cc or 20 cc lignocaine, okay, depending on the percentage, draw it, and you go and feel for your nerve. You feel your artery, go laterally, and you infiltrate, and you give your block. Okay, give it 5 minutes for it to work. The patient will be numb. Tell him to move your toes. I'm touching you. He won't be able to feel that. So that's a very good, he'll be very cooperative for you to do this procedure. Okay, if I know we're very brutal in when we don't have these things, you just tell him, you know, it's going to help you for a few minutes, you'll feel pain and we proceed. But if you have capacity and you have the rights of doing this, proceed and do it, okay? It's very life-saving and it helps a lot, okay? So that's one thing. So make sure the patient is pain-free. I've done my block. So what next happens? So I need assistant. I need like 2 people to come in, come and assist, okay? So, so you'll come on this side, okay? This side, just here. So she's holding here. Someone else come on this side. On this side, just stand on this side. So what happens? This is the skin traction. So most of the time what I do, they say for 10 centimeters, me I normally use my fingers, okay? Like 4 fingers, okay, should be a space from there. This way it gives a good proper traction because you need space. So I do this then make sure at the malleolus it's well covered, okay? So 4 finger breadths or whatever centimeter you want to use, okay? Then just hold here and then hold. So this tape we normally remove, okay? So it sticks on the patient, okay? You do that, okay? So I've given the patient analgesia, right? So I pull my leg, right? I have reduced it, okay? It will be very lax and easy for you to do this. So I've done that, I have this, so the next thing is to secure, okay? So what do I do? So there is different methods. Some people go above, some people go down. Regardless of how you do it, you can do it, but it has to cross above each other 50%, okay? And then the other thing is make sure you have not tightened the leg so much that you get compartment syndrome. That's the most dangerous thing you can do for the patient, okay? So what do? You tie at the malleola, okay? Make sure the malleola is here. That's where I start my tying knot. So me, I go above like this. So you just make sure you put a bit of tension, okay? But not too tight that you get compartment syndrome, okay? So it should be firm so that it can play the role of what it's supposed to do, okay? So you can go around it, you can go even above the knee. And then you secure, okay? So you can use a tape. Can you assist me with the tape there? So you've done that, okay? So after you've secured, the next thing is to actually put the Thomas splint, okay? So that's where now the other thing you need to be sure about. The Thomas splint, it's life-saving, yes. It's going to, like this patient can stay immobilized for almost a week. The patient can stay with this thing for almost a week as you wait for the orthopedic to come, for you to transport a patient or if you know how it takes our process to do. So he's going to be pain-free, he's be able to sit up, eat his food. You want to be called every 5 minutes to give morphine and analgesia, okay? So you'll be giving him the regular medication, all right? So now the challenge with this thing, the most important thing is to avoid this metal sitting on the greater trochanter of the patient, or the butt, and the patient gets pressure sores from this. It becomes very difficult to heal, okay? Because the patient is so much pain, you think actually it's the fracture. Kumbe the guy is getting pressure sores from here, and then you have another story to deal with, okay? So what do? There's a way you measure for this. And the way you measure is actually measuring between the gluteal fold of the patient or the normal leg, you measure. And then you add 10 or 15 centimeters. That one, because you expect this leg to be swollen, right? Then you come and measure this circumference. That gives you the right size of where the patient actually, if it's the right size, okay? But I know in low resource setting, you may basically have one, right? So just make sure it's quite comfortable. You get it and you have inserted in the right position. So this is the right leg, yeah? But this one looks, yeah, it's actually the right side. So you can actually insert this, okay? You see this pointed edge? It should be lying on this side. It should not be on this other side for the patient on the right leg, okay? So he's going to be sitting on this, making him more uncomfortable instead of causing him more pain-free or causing more damage. All right, so what happens? My assistant will lift the leg as I try to place it in. Remember, doing all this patient is already, can you imagine if you don't have a block? What happens? Will you allow me to do all these maneuvers? Yeah, so you do this. Make sure it's actually, sometimes you can even use a pillow, okay, to make sure it's a bit comfortable, okay, that way. Then the next thing is actually to secure, okay. So what you do, you can tie a knot here. You're not tying a knot, you're just putting this. So you have your weights. I assume we have weights. We have pulleys, right? Yeah, so, yeah, you have jerry cans. Okay, it works. It still works. You get my point, yeah. As long as it works and it saves the person's life, it's not rocket science. We don't need to say, oh, we don't have pulleys, then we are not using, okay? And then you put it like this, and then you attach your pulley down here. So basically, they normally say, is it 10% of the body weight? You can put the pulley. That's what you can do. So it's 80 kgs, 8%, it's 8. So you put 8, so that you have very good traction. Okay, so you'll see the legs actually pulled. He'll feel a bit of discomfort, but you've already given a block or whatever it is, so the limb is going to be secured. Understood? Okay, you want to try? Yeah. Yeah. You can try to put something to stabilize anything, because sometimes you know your thomas splint cannot be reaching up there. So anything to make the patient a bit comfortable. Okay, anything. You can use sheets, you can use pillows, anything to make it comfortable. Okay. All right. So. No, it's femur fracture. Only femur fracture. You cannot put for the tibiofibula. That one you just put a back slab or you put your blocks, whatever you have. Okay. Yeah. Any questions?
Yes.
Yeah.
We're supposed to secure now the limb to the thomas splint with a crane.
No. It's stable like this because you have put your skin traction. Yeah, he won't be. You also want the patient to move. Okay. The more if you put the guy fixed like this, not a good thing. So when he has this thing here, you make sure you check your capillary refill. Make sure it's immediate. Make sure you have a good pulse. Make sure the color is good. The moment you see it changing in any of this, you know you are forming a compartment syndrome. You need to release your skin traction. Okay? Yeah.
So does it mean it will be steady enough even if you need to move the patient?
Yeah, you will. You will. You will, yeah. But you see now, if you're moving the patient to an ambulance or something, obviously you remove the thomas splint, right? And you have your skin traction, you also disconnect it. I think it's something like 10-15 minutes. And then once you put him in the ambulance, you reinsert your thomas splint. It's just a support, because it's elevated. It makes him a bit comfortable. If you have injured yourself, we always tell you, elevate your hands or elevate whatever it is. So it's a good, comfortable thing. Because you cannot pull someone's leg on a firm surface like this. Chances of you forming sores on this area is going to be high. So you need comfort here, and you pull, you have a pulley here. So you're doing a skin traction, but this is what supports the leg. Yeah. No, it won't play a role. It has to be the shaft, yes. Because you cannot pull the neck. You get my point? Yeah, you can't. So for that kind of neck, just give your block so that the patient can be pain-free. That's it. All right? Yeah. So you want to try?
And then the bandage, will it go up to knee or the above?
No, it's just above the knee, not where the injury site is. It's just to help with the traction. It's just to secure, yeah. Let me roll it very well.
To do the block. Lateral
To the femoral artery.
Sorry?
Lateral to the femoral artery, yeah.
We have a question about how you measure the ring
There?
the ring size.
Okay, yeah. Okay, I've even summarized for you guys here. You measure the oblique surface, circumference of the thigh immediately below the gluteal fold of the buttocks and the ischial tuberosity. Okay? Measurement should correspond with the internal circumference of that one, thomas splint. Then measure the distance from the groin to the heel, add 15 to 20 to allow plantar flexion. So this one is the length now. Okay. Yeah?
This bandage,
Yeah.
is resting on it, right?
Yeah.
It's necessary first to do that.
You have to, this one, yes. Most of the time it comes, yeah? Oh, okay, thanks.
So wenye tumekuja saa hizi unaweza tu
Chest tube?
recap ya
Chest tube.
yes, na hiyo.
Okay, sawa. So guys, do you want to practice?
Maybe I missed the
Yeah?
show how to do it, the nerve block.
Oh, the nerve block. You guys have not done procedure sedation? You have not done? Oh. Oh, you just did sedation.
I have a question.
Yeah?
Whenever I don't have
traction.
Skin traction,
Skin
yeah?
traction.
What do you normally have in the, I know there's something,
Thomas Splint.
only?
Yes.
Okay, so how do you, like even, like those things, there's something you normally put like a block.
Do you do any traction in your facility?
No, only splinting. And
Oh, you
go
transfer.
to transfer to the
So, but then I think the best thing is to splint than to put a Thomas splint. Yeah, just splint. Because by putting my legs up here, you're not helping me in any way. You're not. You get my point? Because you need to reduce the joint. You need to reduce pain. That's what happens. Yeah.
most of the time you find that we use the Thomas splint.
You tie the.
Thomas splint as
Oh.
transfer the patient.
Oh, really? So it becomes like a. And what do you immobilize with here?
It's only the grape.
Or you use the crepe?
Yes.
Okay, so you use that as a transportation?
Yeah.
Or not something the patient sits with in the ward or something?
No. It's
Oh.
only splinting as you.
As you
go
trans-
to-
okay, then that's fine. I think that's okay. I thought the patient stays in the ward as you wait for the surgeon. Oh.
Even of accident,
Oh.
you can mobilize.
Okay, yeah, that's fine. You just immobilize like this and then you use your crab. That's fine. That's something good I've learned today. You can use that. Oh, I thought, most of the time we do this because low resource setting. We don't have orthopedics, we don't have ORIF, which can take almost a week or two to be done. So you just do that. Yeah. So about the nerve block, so what happens is I don't know if anyone is willing to be palpated. So when you palpate even for yourself, you'll see the femoral artery. Okay? Medial to it is actually the vein. Okay? Lateral to it is the vein, is the nerve, sorry. So once you palpate, you feel the artery, you go to the nerve. Never leave your hand there. Okay? Make sure your hand is at the artery. It's actually pulsating on you. Then you take your syringe. So me, most of the time I do this. I have my artery, I have my syringe. I take my 20 cc needle, I take my lignocaine. I'm sure I'm there. I hit as I pull to be sure there's no blood. Especially when you hit the nerve, the guy is going to jerk. Because nerve gives you a very kind of pain, like paresthesia kind of. So once you hit that, just tell him, very sorry, few minutes, then you puncture. But you make sure you draw to be sure you don't have blood. Once you draw and you find you have blood, just come out, try again. Okay? Until when you pull out, you have nothing. You know you're actually in the nerve and you infiltrate. Okay? Otherwise, you'll be giving this guy the whole week analgesia, morphine, whatever, as you're waiting for the definitive management. You go for the nerve, femoral nerve, yeah.
No question, but where is this sitting?
Sorry?
This here.
At the
This is-
gluteal fold.
The gluteus is here.
Yes.
Okay.
Yeah, so below the gluteal fold, it's where it sits.
Okay.
Yeah, not above it.
Lateral.
Below it.
Yeah?
Like an outer.
Inner, yes. Yeah. The shorter surface is always the inner part, yes.
How long will the nerve block take?
So it depends with how much concentration you have used. Okay? Sometimes if you put adrenaline, it can last you even 6 hours. Okay? It can stay 4 to 5 hours. If you just use plain lignocaine, it can work for 4 hours. You get it? If you add adrenaline or something else, it can last you for 6 hours. So you can imagine 6 hours of not giving any sedative. Yeah, it's a good pain control.
How much adrenaline?
So it depends with your concentration of your, of your lignocaine. It's supposed to be 1 to 10. 1 to 10. So, and then it depends with your adrenaline. Yeah, 1 to 10. Lignocaine to adrenaline. And then it depends with your, there is adrenaline of 1 to 1,000 and 1 to 10,000. So it depends with how much concentration of adrenaline you have.
And how much
Yes.
lignocaine are we using?
Me, I normally use 15 to 20
So, okay.
Yeah.
So we'll be using like one to two.
mils of adrenaline. Yes. Which is something very small. Yeah. So you mix them together and you push. Yeah. The adrenaline gives vasoconstriction, so it makes the blood, the lignocaine last longer. Yes. All right? Okay.
So that block you can use for any fracture of the leg.
Okay, yeah, it actually gives anesthesia of the whole limb. Okay, but ideally we normally give for femoral. If you have a fibular fracture or an ankle fracture, it's good you could do something called hematoma block. Hematoma block is, you know, when you are injured, the broken bone normally forms blood clot, right? So you'll see a bruise, you'll see swelling, pinkish discoloration, you know that's a hematoma. So what do? You take your lignocaine and puncture in that hematoma, directly in that hematoma. You aspirate, you find it's actually hematoma, and you infiltrate.
And if there's no hematoma?
Most of the time you'll have hematoma even when you have a fracture. Even if you are slapped right now, you'll always have a bruise. So you will have a hematoma. That's one stage of healing that you'll always see, it's a hematoma. Yes. Okay? Right. Any other question? You don't want to practice? Amma, you've already learned it.
Yeah,
You're good? Okay. You've learned.
visual. We are visual.
Visually.
Visual.
Okay.
Class, eh?
Oh,
Yeah, just tube now. And then all of a sudden nimekuta.
Thomas Splint. Oh, okay. Chest tube tulifanya kitambo.
Ilikuwa imejaa.
Oh, it was full, yeah. It was very full. So, how many of you have not done chest tube? You have not done?
Tufanye tu return demo by the way.
Another demo. So that at least you have a less number of people so that you can all see, yeah?
Hizi scalpel ziko hapa everywhere.
These were? I thought I told people to remove them. Chaps, yeah. Make sure you discard your sharps, please. So what else? Are you guys enjoying yourselves? Have you learned a lot? Really? So what should we improve? It cannot be perfect. Of what? Oh, you want us to do more? Hey. More days.
It's a chance for us to leave the county.